Hi, my name is Megan Scott, and I am here today with Dr. April Braswell. I am a nurse, GNSA liaison for the University of North Carolina at Wilmington, where I am studying my master's in nursing education. Thank you for being here with us today, Dr. Braswell. Can you please go ahead and introduce yourself and tell us about your educational preparation, your certifications, and credentials?
Well, thank you for having me here today. So, as you said, my name is April Braswell, and I work at the University of North Carolina-Wilmington for my primary position as an associate professor there. And I am also a part-time pediatric nurse practitioner in a federally qualified health center here in Wilmington, North Carolina. So I am a registered nurse, of course, and that was my bachelor's degree, a BSN, and then I received my master's of science in nursing at the University of Tennessee. My bachelor's degree was actually at the University of Central Florida. And with my MSN, I became a certified pediatric nurse practitioner, where I took a PNP track and then became certified. And then I went on to get my PhD also at the University of Tennessee in Knoxville, so an R1 institution. And so I practice as a doctorally prepared nurse, APRN, as well as an academic professor.
Thanks for sharing that with us. You've done a lot. So leadership and the development of a leader in nursing often begins early. Can you describe your early nursing work and your career as an RN and how that led you to the decision to pursue graduate education and eventually your doctoral degree?
Absolutely. So I'm going to start with peds is the best. So I say this to myself
Yes.
all the time. Of course, I'm a peds nurse at heart, and I'm a peds person at heart. I happen to think that animals and children are the coolest. So, but when I first started out nursing, I've been in pediatrics my entire career. So we're over 20 years now. I just start saying 20 plus now as I age, but I've always been in peds. I started my RN practice in peds, MSN and NP practice in peds, and I'm still in peds, teaching peds. But when I first became a nurse, I remember being so excited. And in that first and second year, this was a good thing and a bad thing. I became really good at skills. I became very, very good at skills. I mastered needle procedures in children. One of the things in kids that's different from adults is, when you try threading a 25 gauge needle through the vein of a 3-day-old neonate with jaundice and dehydration, you have to become good at doing those kinds of things. And so I worked very hard with some of the mentors on my unit to get very good at that. So I started mastering these skills of accessing veins and central line access and getting, certain credentials and certifications to do even more advanced things like this. And I started getting really great at it. But then I started realizing that every time I walked into a child's room, because we had many patients who were there often, right? They had chronic illnesses and they would come back, cancer patients or patients with cancer, patients with cystic fibrosis, chronic, hematology diseases. Every time I'd go in, they would be like, not her. And I remember being like, oh, because I became well known for being the nurse who was the skills nurse who always hurt them. And that was awful for me. I didn't like that feeling. And then I started learning that every time I went to a different unit, because then I got even more advanced, they started saying, oh, well, could you go to the whole house? Will you do the resource and you'll float to all the units? And I remember thinking, okay. And then the same thing would happen on other units. I'd go and these kids would know me and they'd be so scared to see me. And I became really burned out mentally on that feeling of something else has to be done here. What can we do better? And then I also started realizing the policies for pain and comfort for children related to procedures were subpar. So I'd go and all of these things we had available to use, nurses were too busy to take the time to, implement some of these things like EMLA cream or, a freezing spray or, it wasn't the nurses, being poorer with pain management. It was really more that the reason they called me is because they had 5 patients of their own and were so busy that they needed some help. So I'd walk in and I'd see that we just had so much at our disposal that we were not using. So my work and my desire for graduate education began right there, because I did a needs assessment, started looking at the entire hospital where I worked. I worked with anesthesiologists and with the Nursing Research Council, became a member of that council, started writing pain policies for procedures for kids, and also even new pain policies that probably sound kind of old now. I won't even age myself, but things that were innovative then. I worked with anesthesiologists to say, nope, can't do that. Nurses can't implement that, but they can do this. Or we've got to, if you want this, then you've got to have these kids on a pulse ox, because some of these medications were sedating, right? But it was that time I was like, all right, I got to get my master's degree. I need more knowledge. I need more research behind me. And that was why I led to go back to graduate school.
That's so inspirational, because it feels so real as someone who is a pediatric nurse and has been in pediatric nursing most of my career. That really is
You get it, right?
so true. Yeah, yeah, absolutely.
Probably,
Oh, what were you going to say?
that it's probably still true today, that you walk in and
Yeah.
you know, policies and procedures that need lifting, that need evidence building, right?
Yep. Yeah, so you talked a lot about the importance of mentors, and it sounds like you've very naturally kind of become a mentor. I feel like as I've taken your class, you serve as in a mentorship kind of role modeling way for me as well. Can you tell us a little about your leadership as a nurse practitioner and a master's prepared nurse, and how you lead in this area related to child health outcomes?
Absolutely. So when after I got my master's, I stayed in line with that pain management idea and really focused on how I could contribute to care of children in that way. And going from acute care as an RN who worked in the ICU and the, NICU, so that's neonatal, pediatric ICU, emergency room, urgent care, very different from hopping from that to primary care as a nurse practitioner, but still so valuable, because I began realizing I got continuity of care, right? So I would see a neonate, and then I'd see them 3 weeks later for their 1 month check, and I'd get to love all over the family. And family-centered care is one of the things that was really meaningful to me. I could see a child at birth and tell them at age 4, I knew you when you were born, right? And I did that. As a nurse practitioner, I was able to do that to many kids because I stayed in the same place for a while. But as I merged into that position, I started realizing that there is more than the absence of pain when it comes to comfort management. And that was when I came across really focusing on comfort theory and the holistic comfort theory of Catherine Kolkava's. And so I really used that theory a lot in my practice. And nurses will constantly tell me, I don't use theory, that's for school. And I'll say, tell me about how you practice. Well, what do you know? They're using comfort, they're using caring, they're feeling like they were a beginner and now they're an expert. Well, what does that all sound like? It sounds like theory. We use theory as nurses and we don't even remember or realize that we're doing that every day when we implement. But as I started really grasping onto this holistic comfort care model, I used it a little bit in my master's degree, but I really focused on it as a nurse practitioner, because I started implementing more care to my families and my patients from the physical, psychospiritual, sociocultural, and environmental domains. So when I saw a child who came in to see me with an ear infection, I wasn't just prescribing amoxicillin. I was prescribing amoxicillin. Plus, I was telling the parents, all right, here are some things you can do in the environment that might help. He's got ear pain. It sometimes causes headaches. Decrease the lights a little bit. Then I also would tell them, this can be hard on parents when you have a baby who's sick with an ear infection. Call in some resources, get some help, have dad stay home, have grandma come over. That's that sociocultural domain. And then, I would add in all of these things, and I might say to them, whatever you do spiritually, whatever helps you connect, do that. If you search for the sacred in this way, help that, use that right now, because it's a trying time when your kid's really ill. That brings in that psycho-spiritual domain. So, and my patients, I felt like, this was really just purely anecdotal at the time, but I felt like we're more satisfied. And I got a lot of requests. Can we see April? So that felt good, but it was also, I started, without being very like, oh, you should do this, others were asking me questions. You know, physicians would ask me questions, my nurses would ask me questions like, how do I do that? You know, I really kind of want to make sure I'm doing a holistic approach, whatever you're doing. And it's simple. It's just making sure that you're taking care of the whole patient. And that's one of the biggest things that I realized with kids is, and it's different with kids than with any other population because we have the whole family every time they come to the doctor most of the time, right? So we're dealing with a true family-centered approach. And so when I was a nurse practitioner, as I started merging into realizing I wanted to do more work in that way, that was when I wanted to become a PhD prepared nurse. So, but primarily my outcomes as a nurse practitioner really lead in that holistic care domain. And then I also serve, and this stemmed from my work as a nurse practitioner, Dr. Catherine Kolkaba, who is the theorist that developed that theory. She reached out to me because I was doing so much work in her area and asked me to join her. Like essentially, if you were to go to Catherine Kolkaba's website, my picture is there because I serve as one of the international experts in her theory. So I respond to all of her emails and I respond to all of the students who want to know about her work, and I help them integrate that theory into their research, their student work, etc. So holistic care really is where I was as a nurse practitioner as far as outcomes and leadership go.
Wow, that's really cool to hear you talk about putting the theory into practice and really identifying that that's what it is, and identifying that evidence-based care. So as a PhD prepared nurse, you've been taught about the discovery of science. How do you think your research affects outcomes of science and leadership?
So I definitely love research. I am a research nerd. I say that to peers and friends and nurses all the time because I sometimes think that we have this, nursing sometimes does this thing where we want to dichotomize degrees and say that, oh, you must be a PhD to do this, or you must be a master's prepared nurse to do this. Well, I don't know about you, but I was engaging in research as an RN without higher education. We did it all the time because we knew, all right, we have to do these central line bundles because that's best practice. We have to make sure we're cleaning this because that's best practice. We have to make sure that we are decreasing this because alarm fatigue is a real thing. That's all research. We would engage in these things, and these outcomes would come on these units and for these kids without having an advanced degree. So my PhD really helped me advance that, but I want to make sure that it's clear that a leader begins where they want to be a leader, right? It doesn't begin with our higher education. It begins really with where they're showing that leadership movement. You can be a leader as an RN with an associate's, or you can be a leader with a PhD, and that's important to note. But as a PhD prepared nurse, my work continued in holistic comfort care. Okay. So, and then what started happening is it started branching off into other areas. So now when I do holistic comfort care work, I'm not doing it in just little kids. I do it in adolescents. I have written and published on it with students. I do it with faculty, and I've implemented it in my teaching instructional materials in my course. Right now, and probably one of the biggest ways that my research will be impactful and contribute to outcomes of kids is through a research instrument that I developed. So when I finished my PhD, I did a research study where I was exploring what is holistic comfort care to kids who are getting invasive procedures. I met with these children and I met with their parents as dyads, and I interviewed them. Kids as young as 4 years old were talking to me for 50 minutes. I remember my chairs telling me, April, you're not going to be able to get a 4-year-old to talk to you that long. I was like, oh, hold my coffee. I mean, sometimes, and that is part of our bias as adults, we don't give credit to these little ones who have a lot to say. And they are developmentally and cognitively capable to talk when they are asked the right questions for their development. So that's what I did. I talked to kids between about the age 4 and 7 after they had an invasive procedure done. So I strategically planned it to where it was very closely timed with something they had that was pretty invasive and painful. And I asked them, non-leading questions with some crayons and some paper by their mommy, daddy, grandma, whoever was with them, aunt, uncle. so they would feel safe. And I just had them sit down and color and play with some toys and talk to me about this. And I came across essentially the same types of domains and contexts that Kolkaba did for kids. Even kids need a holistic approach to procedures. And so from that set of research interviews came the development of the storybook instrument that I developed for children. And then after you develop it, you have to test whether or not it's feasible. So I can't just say, hey, here's my tool, everybody use it. I went into a hospital here in Wilmington and I worked with the nurses on the floor and I said, tell me what's wrong with this. Tell me what's good with this. And then I also met with children and I asked them about each page on, after it was used, each page on the book. And so that's called cognitive interviewing. I got a really good in-depth perspective from the children of what they thought of each one of these pages. So the storybook that I created, I hired a professional artist who drew all of these animated pictures for each one of the questions or the items, what we would call items on the page. And the kids gave me feedback. They're like, yeah, this kid looks scary. So we got rid of that kid on the books, right? Or, like one of the feedback for the tool was, and it was so precious, this little boy, I'll never forget his face when he told me, he said, when I look at these boxes, I feel like small should be a little box. And I was like, I looked right back at him and I was like, I don't know why I didn't think of that. And he said, that's why I'm here. And so essentially what he was trying to tell me is because kids think so concretely at this age, he was trying to say that when it was a little bit of pain, make a little box. When it was a moderate or medium amount of pain, make it a medium box. And then when it was a large amount of something, make it a big box. And so we changed that, right? And that cognitive interviewing really helped to increase the validity of our tool. And so the very final step was the psychometric analysis. And saying it out loud just sounds so difficult to comprehend because I'm not the statistician. I work with an excellent research statistician, biostatistician, and social psychologist. His name is Dr. Ricky Pon, and he's worked with me a lot in this. And so he did helped me obviously with the data analysis, but we essentially had to collect a bunch of data to assess whether or not the tool had some reliability properties and validity properties. So will it get the same thing over and over again? Okay, that's what we're looking at with reliability. And then is it measuring what it's supposed to? Am I asking these kids about holistic comfort, but really we're assessing depression? That's where the validity comes in. So we had to make sure that those things were working. And there are a few ways that you can do that. And in our study, what we did is we took another tool that's already existing with some items on the measure, and we compared, were they the same? Did they get the same type of responses? You could also do what's called divergent validity. So as one thing goes up, another thing should go down. If on my instrument, the kids were saying they weren't hurting, then we should see the things that relate to pain on the other instruments, such as distress, screaming, crying, should go down. And we did. So that study just finished last year, and we just submitted the manuscript for publication this past month. So once it's been published and disseminated, we really have some, real meat to say, okay, this is out here for nurses to use. So we're hoping that gets published. But so this is what it looks like. I don't know if you can see it, but this is the front. All right. And so then on each page, there's a different picture. So this one is about pain. It shows a little girl with a cast on. And so this one is hunger. So it says something about hunger. And they each, there's one, do you have your favorite people with you right now? Because that's important to kids. Do you have a stuffed animal that's soft to hold? Because that's also important in that age and developmental level. So as far as outcomes go, I would say that holistic research that I do affects outcomes. In addition to the work that I do with sexual and gender minorities. So I do a lot of work with adolescents who are sexual and gender minorities, health equity research. I just submitted a paper on spirituality and the protective factors of spirituality for sexual and gender minority youth. And I am also a fellow in the American Academy of Nursing. So that is focused on research and health policy as well.
It's really cool to hear you kind of break down your project and make it just more relatable, because I think as graduate students, in various parts of our nursing journey, it can seem really intimidating and overwhelming. A really good way of breaking down your research to where it's actually digestible and seems attainable.
You know what? That's a great point because I will say that I didn't always do that. I wasn't always able to do that. And I think that is uh, so pertinent here because that's a component of good leadership. So if you're able to take something that would be otherwise possibly confusing, or, talk in a group of people who aren't your area of expertise, but make it understandable and relatable, that is a component of leadership that took me a while to get. I didn't do that right off the bat. I remember talking to people who were in adult care and going things like, oh, I had to thread a 25 into a 23-day-old ex, for 32 weaker, and them kind of going, what, and then I was like, oh wait, they're not peds people, right? Okay, so I would switch that around and said I had a really tiny baby who was dehydrated and I had to start an IV on him, and it was very hard. Right, so those, even when you're among scholars or among people at the same level of your degree or among people who are in your profession, you can still make things confusing if you're not careful. And that is a component of good leadership, I think.
I definitely agree. And I think it's what makes you a really good professor as well. And so being an associate professor means you have a role as an educator. Can you tell us a little about your leadership in teaching and education?
And so I love to teach. I It is one of my favorite things. I don't know that I mentioned this earlier on, but I'm also a certified nurse educator. So um, being a teacher is hard, right? And you're learning that in your program as a nurse educator because you don't just teach, you have to learn all about objectives and aligning those objectives with the work that you give and making sure that the students are able to meet those objectives. And so when I became a new educator, I remember thinking to myself, gosh, I thought being a nurse practitioner, it would be very easy for me to teach others how to be a nurse practitioner, but it wasn't. There was a lot of professional development involved. There was a lot of education I had to get on my own, knowledge building, and things that would help me realize, how do I teach the thing that I know how to do? And that is not streamlined. It is not easy to do. It's, some people are natural educators because they have that to them, but they also still have to gain that knowledge on all of those components that go along with the facilitation of learning and, scholarship of teaching and helping students with good design and good delivery. So as a teacher, I lead in a few ways. So one of the ways that I do lead in teaching is the scholarship of teaching. So in addition to the work that I do with patients and with children, I also do a lot of scholarship work with learners and with teaching. So my most recent publication, and I love when I get to do this, I get to mix peds with teaching and scholarship. It's like the perfect triad. I'm always so excited. So I developed a holistic comfort care clinic. It's a virtual clinic that my students get to go in each week and see a new patient. And it's a safe place for them. Okay, so many of the students that come through my course, because it's a family nurse practitioner program, a lot of them have no experience in peds. So they're not coming to me with all of this experience seeing children unless maybe they have their own kids, and they will tell me in the beginning of class, Dr. B, I literally only know my own kids. I have never touched another child patient. I'm scared. So I have to work very hard at building that comfort from the very beginning. And I do a very holistic comfort approach to teaching. And by giving them this clinic where they go in, each week they'll see a new patient. And they have to diagnose, and they also create a plan that is holistic for their patients. I teach them about those domains that I told you about in the beginning in the theory: physical, psychospiritual, sociocultural, and environmental. And they have to create a plan that touches on each one of those areas so they know that they are caring for their patient holistically. And so it's got some really cool tools with it. I use video. They will see the patient and they see the physical examination and they get a good history and they diagnose, and then they interact with peers, and they have to critically friendly appraise their peers. Hey, I think that's a great choice for antibiotic, but I think instead of 30 milligrams per kilogram per day, this kid has a bulging otitis media. We need to go up to 80 to 90 milligrams per kilogram per day. And the students are told up front that it's a safe space for them to do that in. And they do give really good feedback to one another where they learn from one another in addition to learning from what they do on their own with the tools and the content in the class. And so when we did this clinic, we found that it worked. So they're knowledge enhanced. We did pre-quizzes and post-quizzes, and we did exploring their feedback about the clinic itself. And there was a lot of great positive things that came from that clinic. So I published it. I just submitted it to Nurse Educator last November, and it was accepted. And it is just focuses on the development of a holistic comfort care clinic, but it focuses on the teaching and the learning aspect. So I published it as kind of a, an innovative project where student outcomes were important and teacher outcomes were important. So that is one of the ways that I lead in teaching, is through teaching scholarship. One of the other ways that I lead is through, I talked a little bit about that professional development that I like. One thing that's really hard to master as a nurse educator is design and delivery and alignment, okay? And we know, based on best practice evidence, that good alignment in a course, okay, good design helps students learn. So if they go into your online course, and I'm talking specifically about distance education right now, but alignment matters also in face-to-face teaching and other programs. But when a student logs into your course, if they don't know where to go first, they're immediately, feeling flustered, or they're immediately like, what do I do next? That shouldn't happen. When they go into module 1, they should know, what do I have to do this week? What do I have to do at the end of the week? What reading do I have? What videos? And that sounds pretty simple, right? But when it comes to the design of the course and how it's set up for the students, it's not so simple. So I've gotten a lot of professional development through a quality or standard education and online design program called Quality Matters. And I am a certified peer reviewer for Quality Matters, and I'm also certified in their APPQMR course. So I can help others with designing their course, in addition to helping make sure that my own courses are like that. And my course, the one that you actually took, that Nursing 510 Advanced Health Assessment class, is Quality Matters certified, along with the entire nurse educator program at UNCW after going through that program. So that professional development really helps me lead as a mentor, because I do have a lot of educators that I work with, peers, who are still in the development process and like some teaching and mentorship in that area. So I would say probably that mentorship piece, and then the scholarship of teaching. And then lastly, I think I lead my students. I hope that my students and my learners feel like I lead them in a positive way. I am a very encouraging faculty member. I give lots of critique in a constructive, appropriate and positive way, but it's in a very encouraging way as well, because we have to lead our learners to know that they can do this, and we have to lead our learners to accomplish what it is that their dreams are. So that's that last one.
Yeah, I can definitely speak to that, because I remember feeling very overwhelmed taking your course and just being a graduate student in general, and knowing that I could just reach out to you, and the support and encouragement that you give really does help to push you along and help you to grow and develop as a student too. So I would definitely say that you lead in that way. I want to go back to something you said. You talked about earlier, being involved in policy within your healthcare organizations that you worked at. And as healthcare providers, we sometimes it's easy to forget, but we don't, work in a vacuum. And so I think that there's a lot of the work that we do that it can relate to local, state, and national policies. And so I was just wondering, are you politically engaged at all? And how do you feel like your science and leadership relate to those local, national, and state policies, if at all?
That's a great question. So I would definitely consider myself a politically active nurse. So I'm a PEDS nurse. There are many bills, many laws, many things that affect pediatric practice, right? Many things that are global, state level, national level. So one of the biggest ways that I try to stay active politically is staying in organizations that are active politically. So I mentioned earlier that I am a fellow in the American Academy of Nursing. That is a health policy organization. They're nonpartisan, okay? They focus simply on what will mean best health outcomes for our patients across America. And we do really dabble into other countries too with caring about their health. I chose to want to be a member of this organization because health policy is an area that is important to me. Again, nonpartisan. This isn't really politics. It really is health policy, which is a very big difference. I will always be on the side of what's best for the child and family. That will always be me. All right. And so that's really health policy. That's what I aim for. I sit on 2 expert panels. One of them is theory. Okay, so there is a theory policy panel in the American Academy of Nursing, and then there is a child and adolescent health panel also in the American Academy of Nursing. And I sit on those 2 expert panels. And I get to work with amazing people. Okay, we're talking like way more amazing than me. I sit on a theory panel with Jacqueline Fawcett. Jacqueline Fawcett is like the guru for theory. I remember watching her and reading her books talking about theory into practice and the development, and how when I would read about inductive and deductive, I remember going, I don't know what that means. I know the smart people use those words, but I have no clue what that is. And she said like one simple sentence, and she said, inductive simply means you're building theory. Deductive means you're testing that theory. And I remember going, oh my gosh, that's so simple. But I sit on these panels with some amazing people. All right. The child adolescent panel, I sit on there with the president of the National Association of Pediatric Nurse Practitioners and several deans who are just fabulous in their research and scholarship. So that's one way that I try to stay very politically active, because this organization, its entire purpose is to build health through health policy, and to, the mission is really just to care for all patients in that way. Health equity, diversity, equity, inclusion, and just caring for all patients from a health policy perspective so that their outcomes are good. Additionally, I go to events, right? Nurses Night at the Legislature here, for example, North Carolina. We just had that. I wasn't able to make it this year, but have been several previous years. And I email. Legislators know my name. I have had their assistants write me back. Hi, April. Yes, we received your email. When something comes out specifically about child health, whether it be children are being taken from their parents at the border, or global health vaccine budget is being cut by a lot, I write those legislators. I am writing my congressmen and women. I am writing my senators, okay? And I am telling them, here's my perspective. And I try to stay as active as I can, even if it's just virtually. And that's something we can all do. We can lead in that way, and people can know our name simply by typing our fingers in an email, all right? I am a Shot at Life representative. So I have been inducted as a champion Shot at Life. So that is a company that is essentially known for trying to enhance global funding and global outreach and access to vaccines across the world. This is not just national, it is international. And because vaccines are the #1 source of primary prevention we have for children, I am a very big proponent of helping children maintain the optimum health status that they can. So I do often present and teach and lead in vaccine hesitancy and educating families, parents, and also legislators about the importance of vaccines. And I do that from a very holistic approach. I don't attack people for not wanting to vaccine their kids or wanting to vaccinate themselves. What they do with their own bodies is their choice, but I give them the evidence, okay? I arm them with that evidence. I want them to walk out every day with full armor, with the evidence, knowing what it is that they are at risk for. And then what they choose to do with that evidence, that armor, is their own choice. But I will tell them that armor will be strong with a sword and with a shield and with a mask if they've got vaccines, so that their body can fight those things, right? But politically, I will usually focus a lot, of course, on the child and the family, because that is my area of practice. But I do try to stay very politically active in any way that I can, even when it's just something simple like an email.
Yeah, I like that you talked about just the simplicity of sending an email. Through the GNSA, they have a program called Advocacy Leaders, and they educate quarterly about the different policies and just what that means and how that impacts our practice as nurses and the health of our patients and their outcomes. And one of the big things that they do is when there's so the AACN is focused on nursing education. So some of these are how we as like nurses, nurse educators, how this impacts our future. And so they'll send out templates. So that's like a really simple, easy way. And one of the people who leads that talks a lot about how you like just a handful of emails to a representative really can make a difference because they're hearing something from someone.
And those
So
right? When I send a legislative email, I'll never forget, I had a health policy teacher when I was in my master's program that was like hook, line, and sinker. Hook them in with the personal stuff. Get the line and sink it down, right? And so I will tell stories about patients and about, and making sure, of course, that I'm not releasing any private information, but I will tell stories so that they can understand what it is that I see every day or what it is that I'm seeing in practice or I'm seeing, in nursing education or one of the areas of health policy I was focused on was also when COVID was going on, how they needed PPE. All right. And how is it that we got to a point where our nurses were reusing masks for several weeks because we didn't have funding or we didn't have the ability to give them that when they were there on the front lines caring for these patients? And my friends are calling me with scarred noses and ears blistering. And I'm thinking to myself, I got to do my part, right? That as an RN, we make up the largest healthcare force in the nation. Okay. Doctors are powerful. Physical therapists, pharmacists, they're all amazing. I love our interprofessional and I love our interdisciplinary work, but we are the most prevalent healthcare provider in the entire nation, making up almost 5 million healthcare providers as RNs. We have power. We don't always know it, but joining organizations and having a voice with that many people can make a difference if people were to do, if they were really to use their voice in that way. I do sit on the editorial board for AACN's journal. So I'm one of their editors, and AACN does a lot of amazing things when it comes to policy work. The Journal of Professional Nursing publishes a lot about that when it comes to policy and care and, students and teaching and stuff. So that's another area that I focus on.
thank you so much for sharing so many pearls with us. What parting advice do you have for the next generation of nursing leaders?
I think I would say avoid those who tell you that you can't. Okay. So stay away from the negative people when you can, because those people can be very powerful here and in your head and in your mind. Staying away from negative perspectives and negative thoughts is healthy. So stay away from that. Surround yourself around the encouragers, the supporters, the people that come to you and say, hey, Megan, you're doing so amazing. I want to learn some more of that. Tell me about it. Where are you going next? Those people exist. And I keep them in my circle because I need them when I'm having bad days. All right. But I would tell you and others that the most important thing for us to do if we're going to become a leader is to stay away from the negative battle in our own mind. Okay. We are our own worst enemy sometimes when it comes to leadership. Sometimes the things that hold us back is our own head telling us we can't, or our own trauma history that has gone in and taken something from us that allows us to really be free in our thoughts sometimes, right? So really trying to stay away from that negative battle in our mind. And Bernadette Melnick, so she's known in nursing as pioneer in evidence-based practice, okay? She's awesome. I just got to see her in person last November at the conference for AAN. But I remember watching her talk one day that evidence tells us very, very clearly that what you think is directly connected to how you feel, which is then directly connected to how you act. So if you dip in over here and focus on those thoughts that are positive and just take away the ones that are leading you to not do what you want, then you're going to feel better and you're going to act differently. So really try hard to focus on making sure my thoughts, my mind, my cognition is in the right place for success. And that means I can do this, I matter, I can make a difference, and I can affect health outcomes for nursing and for my patients and for my learners, my students. So stay away from the battle in your mind and take a hold of those positive thoughts so that you can feel and act better. And that's it.
Dr. Braswell, thank you so much for spending this time with us today. As a pediatric nurse and someone who aspires to be a change agent within the nursing profession and beyond, your story is really inspirational. And I know that it's really going to have a big impact on nursing students across the nation. So thank you so much for sharing with us.
My pleasure.